Hello, this is Mrs. Condry. This is fluid and electrolytes for the perioperative client. It's really storming outside, so you may hear some thunder in the background. Our objectives is that we will identify the physiological responses of the perioperative client in terms of fluid and electrolyte balance, which we have spoken about quite a bit in the previous videos, and we'll classify the types of IV fluids used during the perioperative period. Fluid volume deficit is an abnormal loss of fluids from several causes. Could be from vomiting, could be from diarrhea, fistula drainage, it could be the patient really hemorrhaged during the procedure, could be that the patient is diuresing for some reason. The signs and symptoms are restlessness and confusion, so those are the mental changes, mental status changes, and they could be very lethargic. They complain of thirst, that is if they're awake. So those patients that are not awake, of course, cannot complain of that and let you know that there may be a problem. They could be tachycardic, and they could have postural hypotension, and if it's very severe, they will have hypotension without just postural changes. But dehydration is not interchangeable with fluid volume deficit. It's a loss of water, but not sodium. So our goal is to replace water and electrolytes with IV fluids in the intra-op and post-op periods. Isotonic or 0.9% sodium, normal saline, all those are the same name. Normal saline is 0.9%, is given for rapid volume replacement. Lactated Ringer's has water and electrolytes. So isotonic or 0.9% sodium has 0.9% sodium and water, but it does not have any electrolytes. Lactated Ringer's does, and so does Normasol R. That's used locally in the area, in the OR. And if the patient hemorrhages, they may order blood transfusions. Fluid volume excess is something you probably won't see in PACU, but you could see up on the unit. It's an excess intake of fluids or an abnormal retention of fluids. Like, say the patient has heart failure, they're weak heart, so they can't handle all those fluids, or they have kidney failure, or they could have a shift of fluids from that interstitial space to the plasma, maybe from the IV fluids that were ordered. So that's why you need to be aware of what the signs and symptoms are, in that for mental status changes would be confusion, and it could be of complaint of a headache. They could have jugular vein distension, crackles in their lungs, shortness of breath, edema, and hypertension. All those are signs of fluid volume excess. So it's not too hard to know the difference in signs and symptoms between the two. Just think excess, fluid is leaving into all the interstitial spaces, and eventually it leaks out. And so our goal is to remove the fluid without causing abnormal changes in those electrolytes or the osmolality. So we accomplish that by giving diuretics and restricting fluid and sodium. Nursing management is through strict INOs and daily weights. We're going to monitor for those cardiovascular changes, respiratory changes, and neurologic changes, which I just talked about. We're going to assess the skin. I want to make sure with assessing skin turgor that you're all aware not to check just the hand, because as we age, we lose our skin turgor. So that's fine to check the skin on the hand for someone who is a pediatric patient or, younger adult, middle-aged. But as we age, we lose our collagen. So it's good to check either here on the chest, or the forearm is a good, underneath the arm here is a good spot to check the skin turgor. So if you do that and the skin remains up, they're dehydrated or they have a fluid volume deficit, and we're going to monitor those IV fluids. And if they have an NG tube, we should not allow them to have free water, because the NG tube is sucking out the lots of water, and giving free water, so they drink free water, it can increase their electrolyte loss. If the physician orders it, usually only if the patient begs, they can have a few ice chips, but it's only with the doctor's order. So now we go to intravenous and electrolyte replacement. So what do those terms really mean? Isotonic, hypertonic, and hypotonic. What does it really mean? Well, it means the amount of solutes in the IV fluid compared to the solutes in the cell. So isotonic fluid has the same amount of fluid in the plasma, so it's infusing the same amount of salt or solutes into the plasma as it's already into the red blood cells and the cells in the body. But hypertonic IV solution has more solutes, more salt than the cells. So that means there will be a net movement, and hypotonic has less salt or solutes than the cell. So now let's talk about the isotonic, which is all IV fluids that I'm going to talk about here for isotonic, hypertonic, and hypotonic are crystalloids. I'll also talk about colloids, but crystalloids are, isotonic crystalloids are good for fluid replacement for that fluid and sodium loss. It's good for patient hemorrhaging, and it's good for hypotension. So what happens is the amount of water in the cell and the amount of solutes is the same as the solution that you're putting into the plasma. So there's net movement, but between the cells and the plasma, but nothing ever really changes because it's isotonic fluid. And until eventually, after days and days, there may be you might have fluid volume excess, and things may change then. This is just short term, good for those fluid and sodium losses, and examples of that are normal saline or 0.9% sodium chloride, so that's the same amount of solute as in the cell. Lactated ringers I talked about, and Normasol, both contain some electrolytes, different amounts of the electrolytes. And I wanted to talk to you about D5W, or dextrose 5%. Even though it's classified as a isotonic solution outside the body, it turns hypotonic as soon as the body metabolizes that dextrose. It's only about 190 calories in the whole liter bag, and our body quickly metabolizes that sugar, so it can cause the cerebral edema. So we don't really want to use D5W as a isotonic solution because it really isn't. It is a hypotonic. So now we talk about hypotonic solutions. They're good for maintenance fluid because our normal daily losses as we breathe out, as we sweat, those normal daily losses are hypotonic. So it's good for maintenance fluids, but if it's in high concentrations, what can happen is that it can cause the cell to swell. Oh, well, I put the wrong slide here. It's isotonic on this slide, but it really is that it can cause swelling. So think of hypotonic like the hippo example that I gave last semester, that it's big, it can cause the cell to swell, and eventually the swell could burst. The examples of hypotonic solutions are 0.45 sodium or half normal saline. So remember, isotonic is the 0.9%, so half of that would be less than 0.9, less than equals hypotonic. And I already talked about the D5W. Hypertonic solutions are good for treatment of hypovolemia and hyponatremia. So we have not enough salt in our serum. So what happens is that the solute concentration in the cell is lower, and we have more salt in the solution that's coming in. So the cells shrink as the water goes back into the serum. So in that example, it's like oh, I'm moving so fast, I'm skinny. So the cell gets skinny. So if we do have to watch for signs of that intravascular fluid excess, because if all the cells are shrinking, it's going into that into the serum, and you can then get wet lungs, hypertension. And examples of that are dextrose 5%, so in half normal saline, so that's D5.5, D5.25, D5 normal saline. So all those have more solutes. And 3% sodium solution is ordered often for a severe hyponatremia. So the patient has very low sodium, so the hypertonic solution is ordered to put salt into the serum. Intravenous additives into the solutions are often, potassium is very, very common. Calcium chloride can be added, magnesium sulfate can be added, sodium bicarb. They're added specifically to replace what that client's labs show is low. And if they're getting TPN, total parental nutrition, the pharmacist looks at their lab and decides what they need in their solution. Colloids are plasma expanders. What happens is that it stays in the vascular space and it increases that osmotic pressure. And examples are albumin. And albumin can be ordered at 5% for plasma volume expansion, or 25%, which is hypertonic, and it draws fluid from the interstitial space. It's good for edema, and the reason it was saying in the book that it was good for ascites is because if you pull off, say, a liter or two of fluid from the peritoneal space, the patient can have signs of sudden loss of fluid. So we want to give a volume expander. But it also can draw some of that edema back into the serum. Plasma or blood is especially good for hemorrhage, of course, and it's usually packed red blood cells used to avoid, not whole blood. Whole blood can cause the volume overload, so usually they order packed red blood cells, and they'll also order normal saline. Dextran is another colloid. It helps pull fluid back into the intravascular space, and hetastarch is a synthetic dextran. So we have talked about those responses of the perioperative client in terms of fluid and electrolyte balance, fluid volume excess, fluid volume deficit, and the types of IV fluids used during the perioperative period are usually the isotonic, which is lactated ringers, Normasol, or normal saline. But typically lactated ringers and Normasol are the fluids that are used in the perioperative area, and then once the patient is into PACU, the doctor may order normal saline instead. So that's it for fluid and electrolytes related to the perioperative client.